putting on San Diego Shoulder for another year. It's always more fun to be in person, but this is a wonderful other opportunity. So I'm going to be talking about pathway to ASC total shoulder development, and really excited to actually talk about this because this was a large part of the last 5 to 6 years of Dr. Anna and I's practice together. So no relevant disclosures. So how do we know a TSA patient was not a good outpatient shoulder arthroplasty or ASC surgical candidate? Well, anyone who wears a Disney shirt, grumpy as the worst, those person were automatically inpatient only. If they come into your clinic wearing sunglasses inside, can't do them in an ASC. If they write extensive extra history in the margins of intake form, probably not the best ASC candidate. If they mark skin with pen to designate localization of pain, if they take notes during the visit, if they have a protective wristband for their metal allergy, or if they have a first name as their first and last name, and of course, anything multiple is bad, multiple cats, multiple rings, multiple allergies. All these patients were automatically excluded for us in the past, but we got a little bit better. So we focused a lot more on optimization, and I'm going to briefly just talk about our overview of our process for creating this pathway. So we do know that shoulder arthroplasty was historically an inpatient procedure, and there have been drivers for outpatient ASC arthroplasties. We are operating on younger, healthy patients. There is a financial burn to the healthcare system to optimize revenue, and this is a good way to do it. And we have improved pain management and patient optimization. So I'm going to focus a little bit more on the latter there. And then it's also a patient preference. A lot of patients want to save money and go home the same day in the ASC. And Quinn's work really set the groundwork for this. This was his awesome NEAR award from 2016 that looked at 30 outpatient, 30 inpatient TSAs, found no difference in readmissions and comparable minor complications. So once we saw this study, we thought, hey, maybe we could do it ourselves. And the truth is, in 2021, we're able to actually move to the ASC because it was moved from the inpatient only list. And when we started really looking at the data out there, we found that there were substantial cost savings, not only to the patient, but for the hospital if we move to the ASC setting. So all this led us to, hey, figure out how we can make it better in our own institution. And it started with actually partnering with Oki and Grant in our own pathway development, where we really start to look at our data. And we had this 2-institution cohort where we looked at all of these comorbidities that you could see on the right. And the beautiful thing about this data set was we had 2 different cohorts. We had, Grant's high-end, totally optimized patients, and Oki and mine, southern fluffy patients. But it was a really good way to understand which patients would be better in the ASCs. And we looked at multiple different questions. What is a good outpatient appropriateness? What's good for 90-day readmissions, discharge to subacute facilities, extended length of stay? And we used all the comorbidities on the right to really start building our own pathway. So if you're going to build your own pathway for an ASC, looking at your own data is a really good way to start. And we looked at multiple studies. Grant's going to go over these in detail, so I'll just kind of gloss over them. But essentially what we came up with was there were 13 variables that for our 2 cohorts were really important, which was surgery duration all the way down to specific medical comorbidities. And we found these 13 were the most important for our at least demographics. So this led us to really focus on our patient optimization, what patients were best for the ASC setting. And we, there's things that we can fix and there's things that we cannot, innate fix factors like age, gender, genetics, we really can't modify them and optimize for the ASC setting. But there were ones that we could modify, like alcohol, smoking, and nutrition. And I'm going to talk a little bit about how we did that for our pathway development, how it's really changed our practice and outcomes. We looked at different things that we really tried to fix: anemia, glycemic control, all the way down to mental health disorders, obesity, smoking, things that we really thought that we could change. And we created this thing called the PASS Clinic, and it's called different things in different institutions, but it's essentially a way, how do you optimize patients from not only their comorbidities, but from their nutrition status to have the best outpatient ASC result. And what really drove this was when we looked at our own data, anytime a patient returned to the ER or got specifically admitted after an outpatient shoulder arthroplasty, the average complication costs our healthcare system almost $12,000 per readmission. So we really didn't have much wiggle room to make errors in this process, especially if the healthcare system was going to allow us to continue to do it. One of the things that we came up with is alcohol dependence. This was essentially a non-negotiable thing for our patients. If they had more than 2 drinks a day, or we felt that there was any sort of dependence, we would push them into the inpatient setting and actually try and get them to stop drinking at that frequency. And then smoking, patients had to at least have stopped smoking for 4 weeks if we could. We know this substantially improves outcomes, decreases pain scores, and readmissions. So those were two modifiable things we started right off the bat. We also start to look at malnutrition from our two institutions again, and specifically see how it affected readmission. So again, this was another multi-center study between Rush and Duke. We found that there was a high frequency of malnourished patients if we went back our data, 37% for revisions versus 20% for primaries. And really, if you look at it, these patients who were malnourished had worse outcomes. They had a 13% increase in extended length of stay, 8% increase in discharge to SNFs, but no real 9-day readmissions. But we thought that if we could modify this and make it better, the chances of ASC readmissions and poor results would be less. We also looked at just our literature in general and other people's literature showing that malnourished patients, specifically a BMI less than 18.5, had higher complications over every other BMI group. So we really focused on improving our nutrition status of our patients before the ASC arthroplasties. And so we came up with this nutrition score that all of our ASC arthroplasties went through. They essentially do this journal where if they have a BMI of less than 18.5, if they have unplanned weight loss over 10% in the last month, or they're eating less than what they normally have, or if they have an albumin less than 3.0, they're going to have to go to a nutrition evaluation, and we would delay their surgery until we got them optimized. And the question is there a way that we could improve our nutrition supplementation for these patients on top of these dietary requirements that we're asking them? Well, every patient, no matter what, for us, if they're getting an ambulatory outpatient surgery, gets a protein supplement. The best one that we found, and no conflict here, is Fairlife. But it's any sort of protein supplement we'd try and get them to take before surgery. And then we would have these specific supplements that we would ask them to take. We'd have them do leucine, which is good for improved muscle endurance and lean body mass, glutamine, which is improved for immunity and decreased anabolic processes, vitamin C, which is good for increased collagen synthesis and decreased inflammation, and magnesium, which is good for improved muscle synthesis. So we try to get all of our patients to take all these supplements before any outpatient surgery to decrease our complications. And this is something we started doing recently, where every patient 2 to 3 hours gets a 50-gram carb clear liquid drink. This we have found from the literature decreases length of stay, decreases postoperative pain scores, and improves insulin sensitivity. And if you talk to your anesthesiologist, they're usually okay with this. And then we're not doing this, but I thought this would be something new for this webinar to just briefly talk about peptides and culture, because it's coming. You can see that RFK has essentially waged a war with the FDA to bring peptides to our patients. And not this is a political thing, but most of your patients, especially the ones who are well educated, will ask you about peptides. So I just thought I'd briefly go over the different types that there are. There's the BP157s, the TB500, the Glow Stack, the Sermorelin, and the GLPs. And just what to understand when your patients ask about this, the BP157, it's good for improved ligament healing, tendon healing, accelerated muscle generation, and it's called part of this thing called the Wolverine stack. There's the TB500, which is again part of the Wolverine stack, which promotes angiogenesis, apoptosis, decreases inflammation. Again, this Wolverine stack here. And then there's the Glow Copper, which is another one that our patients ask and sometimes try and take, which are good for improved wound healing and antimicrobial properties. And then there's a Sermorelin, which is essentially a growth hormone analog, and it decreases body fat, increases muscle mass, and increases energy levels. And then we all know about the risk of this, which are essentially any sort of growth hormone risk, which is acromegaly, cancer, peripheral edema, and type 2 diabetes. And then lastly, the GLP-1s, we know that this increases bone mineral density, lower rate of osteoporosis, and lower risk of fracture. And a lot of these patients come in and ask about this on a routine basis. And frankly, a lot of our patients are starting to use them at this point. So if you're going to start the process for the first time and you haven't done it, the first thing to do is to work in a familiar setting. And you could usually start this process by doing a dry run in your hospital just in case something goes wrong. Start with good patient selection, which are healthy young patients. Organize the team. Use your team that you normally would use as an inpatient in the outpatient setting, in the ASC setting, and then just organize the process. For us, one of the things that has been super helpful is patient resources, and we spent a huge amount of time working on handouts, and more handouts, Every single patient gets preoperative handouts, postoperative handouts, and we have a huge buy-in from nurse navigation. When the healthcare system saw how cost-effective that this was to do, they invested a lot of resources, and these nurse navigators help manage our patients pre-op and post-operatively. And then we've had a lot of physician supports from cost savings from implant vendors or whatever to make this process more affordable for everyone. And then we got buy-in from the facility, including anesthesia and PT/OT at our ambulatory sites to come in-house and do some counseling with the patient. So huge buy-in from our healthcare system, which has been amazing. So this is our current workflow. Every single patient gets an evaluation from the PASS clinic for optimization nutrition. They have the surgery. In the postoperative recovery area in the ASC, they have a PT evaluation. Then they have a nursing evaluation to make sure that they're ready for discharge, and we keep working with them and optimizing if they're not. They get telephone calls at 1, 3, and 7 days, and it's been a really nice process for us. And we looked at my own data for this, and frankly, it was kind of shocking how bad I was at my readmissions from the ER and inpatient. You can see here, 11.5% readmissions. These were largely medical, but there were some surgical as well. And then when we started doing this optimization process, you can see that goes down to almost 0% in the next year. So if you can follow this pathway and get buy-in from your healthcare system, it has huge effects on your readmissions and outcomes. So in summary, ASC shoulder arthroplasty, the process is just inevitable. The approach should be incremental. Start slow if you're going to do it. Have a really strong, consistent team. Refine the process. And thank you for allowing me to just talk about our pathway at Duke.